Well, good. Dave Fortino.
Hi there.
Hi, Dave. Good to see you.
You as well.
Okay, I'm going to get us going right away. Are you seeing a screen with a slide on it?
Yes.
Yes. And is it a slide and a bunch of faces, or is it just the slide?
I mean, I think it depends on how you're set up, but for me, it's faces and the slide.
All right. Sorry, guys. Let's try that again. See, I need 5 minutes just to get that part fixed.
But we all have control over our own interface, right? I see faces as well, but I don't think you can affect my setup here.
Oh, really? Can you move the faces? If you can move the faces, then I've done it right. Oh,
yes.
Perfect. Okay. So
It
we're
looks
on.
great, Lori.
Great. Okay. Everybody hold the tow rope. See if we can get us all up and through this. So I thought first we'd go through and quickly get everyone to do introductions, which might be harder for me to do. Let's start with Judd Haynes.
Hey, Lori, Judd Haynes, navigator with the Port Townsend Police Department.
And Greg Brotherton.
Greg Brotherton, County Commissioner.
Dave Fortino.
Dave Fortino, Jefferson County Sheriff's Office, Jail Superintendent.
Lisa Ray.
Hi, everybody. Lisa Ray Thomas, University of Washington Alcohol and Drug Abuse Institute, and I work with tribes and American Indian organizations as well.
Pete Brummel.
Pete Brumley's Jefferson Fire Rescue.
And Matt Reddy.
Matt Reddy, Jefferson Healthcare Public Hospital Commissioner.
Okay. Jim Novelli.
Jim Novelli, Executive Director, Discovery Behavioral Healthcare.
Denise Banker.
Denise Banker, Jefferson County Public Health, Community Prevention and Wellness Initiative Coordinator.
Good to have you here. How about Adam York?
Okay, I'm Adam York, data analyst at Jefferson Healthcare.
Good to have you here. Peggy Webster. Or Gabby Caudell.
Gabby Caudell, I'm the clinical supervisor of Believe in Recovery and president of Gateway to Freedom.
Great. Okay. What I'd like to do is take us through the sort of an overview of the deliverables and next steps on the RCORP implementation grant. And then we'll do a quick update on the RCORP planning grant, which we've completed. And then John will talk a bit about IC funding and CHA and CHIP update. And then Lisa's going to take us through the data collection results of all the data you folks put together. And then if we have time, we're going to play something called Addictionary, where we're going to talk about playing Addictionary. Okay, first I wanted to give a nod to Andrew Nelson, graduated from behavioral court this last week. And I don't know how many folks I know end up going to those graduations, but this is a member in our community that sort of watching behavioral health court, you get to see folks, both behavioral health and drug court, you get to see folks going through the process of their recovery journey, and it's always exciting when one of them graduates. So I'll try to feature, as we have graduates in the upcoming months, I'll try to feature them here at this meeting. So if you run into them, you know who they are. Moving on into the implementation grant, I'm sure you guys have all seen this overview that just shows who is on the consortium. That the focus of the grant is the behavioral health services being improved throughout Jefferson County. And there are 3 tabs of focus that the grant looks at: prevention, treatment, and recovery. For each of those tabs, there are very specific required core activities that we need to accomplish or support. And I've listed them here. I'm not going to go through them all individually at this moment, but just wanted to include that as a quick overview. I was presenting, I can't remember what meeting, but I got the question of why is there so little money going out to the community and from this grant? And so I thought I'd give a quick overview of how it kind of breaks out. You'll see in this area, we've got the salary, benefits, travel that's required to Washington, DC. They require 2 folks to go for each of the years of the grant. So there's both lodging and travel for that. And then any equipment that we would need to buy. So that makes up this 45% of the grant funds. And then over in the funding for programs, I should also say, some folks, if they're wondering, well, what does the grant team do that you're paying them, out of this realm? And let's see, I wrote down, we communicate and facilitate the one-on-one and BHC as a whole conversations to coalesce the member data and content into required deliverables. We develop and finalize contracts to get the funding out to the community. We're giving a public presence to the consortium by attending all the relevant regional and county meetings to keep the vision and actions visible and relevant to all of the tables that we end up at. And then we also work to help various consortium members to represent their efforts clearly through whether it's presentations or press releases or advertising articles and that sort of thing. So that's the realm of what you're getting for that bit of money. The funding for the programs, I think you guys are all pretty familiar with the things we're pushing out money toward. The Recovery Cafe, the syringe exchange program we'd like to start down in South County, the Communications Action Plan, HFPD, and what they're doing to help us determine the feasibility for the Crisis Stabilization Center. And it seems like there's one more, but I'm not remembering it. And then, of course, there is this area here, which is what Jefferson County Public Health gets for administrating the grant and general indirect costs. On the grant, I wanted to give you an overview of the deliverables that we'll have for each throughout this first year. You'll see that there are 4 quarterly reports that are due at various, quarterly intervals throughout the year. There will be 2 PIMS reports, and in a second, I'll show you what those will involve. And over here, I've just listed, there are the members that are voting members that will definitely be a part of the PIMS report. I'll be coming out to you for data for those. And then when we're doing the quarterly reports, I'm hoping to get information from everybody, whether you're on the ad hoc committee or otherwise, because all of you folks are doing things that I think it's important for HRSA to know we're doing that weave in with the whole concept of improving access to behavioral health services. The information required from the PIMS report, I'm not going to go deep into this, but I just wanted you to see that there are these major tabs of information that HRSA requires us to collect, and including the service area of the consortium and the consortium members, the demographics of what we're serving, prevalence around opioid overdoses, our direct services. They've got quite a breakdown there that we'll need to figure out how we can best set up something so we're easily funneling that data and not having to pull our hair out every quarter. And then the workforce tracking, how many we have that are waivered and how many folks are providing the mat, and how much volume we've got for the amount of waivered people that we have, if that makes sense. And there's quite a bit there under the workforce tab that we'll be filling out. That gives you an overview of the PIMS. Any questions so far before I run hard? All right. So the grant required activities, I wanted to go a little bit in depth on each of the prevention, treatment, and recovery and show you how I'm trying to set it up and track it throughout these next few years. First of all, we have the strategic action plan that we put together before we knew if we got the grant or we knew what the required activities were for the grant. And so what I'm attempting to do with each one of these, prevention, treatment, and recovery, is to show you how there's a range of actions that we came up with or actions that they want us to do, and we're trying to tie them together so that we can see how we're impacting our own landscape, and so that HRSA can see that we're doing the activities that would impact it. So this sequential intercept model shows 5 opportunities to intercept an individual and connect them with behavioral health, physical, and social services. And in this way, we want to endeavor to connect with the vulnerable residents at an earlier intercept point and avert that potential crisis that can land people in the emergency department or jail where we really aren't getting them the help that they need. And so these, I'll list them out for you. We have community services, so that it's not just these things that you see listed here, but they are opportunities to intercept before anything has occurred in terms of a crisis. And then there's the point where there's the EMS law interaction that we could connect them with services. Also at the initial court hearing or the emergency department detention. Then when they move into the jail, courts, and treatment system, there are all those areas where we have an opportunity to connect them with services when they re-enter, and then back out at community supervision, aftercare sorts of services that we can, that Dave Fortino will be talking a little bit about, that we could impact. And so in the use of this model, I'm trying to make sure that everything that we do shores up something in these different areas. And if you start with prevention, there are all these prevention related activities that we talked about doing in our strategic plan. Then these are the specific elements of required activity for the grant. And so what you see me trying to do over here in this panel is to actually use the action panel as a place to keep a regular catalog of the actions and efforts that all of us are taking, and whenever possible, tie them to any grant required activity that we can. So if we do this every 30 days as we're having our meetings, I think that we're going to have a lot of content to put into those quarterly reports, and it's going to keep HRSA in the know of what we're doing with their money. Or not just what we're doing with their money, but all of the ways that we're trying to make sure that we're really provoking the change that they're looking for. So for prevention, I'm sorry, let me go back here. You'll see that all of these activities are going on, and I need to give a nod to Denise Banker, who has provided a lot of the information here, and she even sent me some more information that I did not get the final bits into this before I sent it out. So I will update that before I upload this presentation to the website. So the work that Denise is doing, or Denise and the team of folks that that she represented as we were talking about what's going on. And I should say that it's not just youth prevention that's going on. That just happens to be all that I was able to capture for this presentation. We know it can be hard to quantify the impact of prevention. If you're doing it well, there's no number for what's been averted. But as Denise and I talked about where to put this, it makes most sense to show that the impact will happen here before anything occurs in terms of interaction with law. And then it could also impact over here. You could make an argument that there's, prevention impacts all the way through, but I think it's probably most easily measured. She had a great term. Denise, you might have to tell me, what was it? Population of reach? Was that the? Okay, she may not be there, but
no, I'm here, but I'm going to have a hard time coming up with whatever term we use to discuss that. But it would be yes, population reach, or aggregate counts, or individual counts. But generally, the work that our prevention team does, particularly when we do anything that is media related or drug take back related, that kind of thing, that's population reach. So.
Okay. It's a new term for me to put in my hat. So then if we move to the treatment tab, it's the same process that I'm taking us through. These are all of the activities that we had in our strategic plan, which, by the way, not this meeting, but probably the next one, we'll start to look closely at in the time of COVID. What should we trim ourselves back to doing first? So on the treatment front, here's what we talked about doing. Here is what is required. And there are 2 slides of what is required. And then over here are action notes where we're going to make the effort to tie whatever it is that we are doing into whatever required area they might be applicable to. Those are the 2 slides there. And then I thought while we're in the midst of the treatment part, we feature something that Ford and Jim Nobelli have been working on together. And I'm going to turn it over to, I think Jim was going to speak first. Jim, I think you might be muted.
Excuse me, I've been on Zoom since 9 o'clock this morning, so I'm a little zoomed out, to say the least. Anyhow, I told her how to keep this brief, but what I really want to talk about is my work in behavioral health, and again, being part of the state mental health system. Obviously, we're moving towards this integration and holistic care and trying to collaborate and integrate as much of many of our services as possible. And it's very, challenging to do this kind of work. And I've done it in the past, but, I came to this area and it's really looking at what can I integrate with, work with, instead of recreating the wheel, or how can I join with somebody else or some other services. We are licensed here at Discovery Behavioral Health to do SUD, but we don't have it. That program is not up and running, but I do have prescribers that can do MAT. And so how can I benefit the community? How can I collaborate? And it's really the main word is collaboration and building relationships and developing those relationships to combine services, to combine things together instead of everybody going in their separate silos. And the idea was to try to bring things together and to use 2 programs together and create a stronger, better response to the community. So there's this gentleman that's down the street from me that has an SUD program. I had the MAT program, and I took a walk down the street. Actually, I was introduced to him a little sooner, and I started having discussions with Ford and how can we help each other to strengthen a response to MAT services or to substance abuse services in this community. So, and then as you can see, we developed this, well, I should say with the help of Lori, developed this wonderful slide presentation on collaboration and working together. And I'm going to have Ford take it from here and why this is so important and how this program affects lots of different parts in the Intercept model that Lori's been talking about.
So the military, for example, has proven over the years that it's cost effective to treat an individual instead of kicking them out of the military and then starting training process over for somebody to replace them. So if they get them treatment and they're successful in that treatment, then they can put them right back into the workforce and it works. So part of what it's going to benefit here is that by working together with Discovery Behavioral Health and Safe Harbor Beacon of Hope, we're going to reduce the amount of recidivism. We're going to reduce the number of individuals going into the hospital, emergency room, emergency department. We're going to cut down on our individuals going to jail. EMS is going to be making less calls for substance abuse related incidents. So if you look at all that, it's going to be a cost-effective process. It's also going to work for employers that hire these people and get them back in the workforce because they're already going to know how to do some things and they're going to be able to successfully put them back to work and hopefully won't have to hire new people and train them all over again. So in reality, it's going to be beneficial to all of us in the long run to treat these people and to work together in the process of taking care of them. So.
Thank you. I'm going to go back quickly to this slide and just say that when this was presented to OCH, they were looking for a regional, for some insight to how they might start to think about this regionally. And so Ford and Jim did their own little brainstorm and sort of came up with some of the challenges and some of the basics and some worthy next steps for the region. So I'm really happy that they've been able to do it, not just here, but it's sort of a starter of a conversation at a regional level. It's nice that Jefferson County is starting that conversation. Now I'd like to go on to Dave Fortino, who's going to talk about the RCEP grant.
Hi, everybody. So yes, the jail, in collaboration with the health department, Anna McHenry and Gabby Caldo from Believe in Recovery, went together to apply for a grant through the Healthcare Authority to establish a residential treatment program at the Jefferson County Jail. So one of the benefits of having a residential treatment program at the jail is obviously to provide a local means for individuals to engage in treatment while they're incarcerated. There's some hurdles that individuals in jail often face when they're trying to get enrolled into inpatient treatment while they're incarcerated. The primary issue being their insurance is suspended. So this program provides funding up to $200,000 to establish that treatment program here. Thank you. So just I'll touch real briefly on some of the requirements here. One of the requirements is to have a dedicated and separate housing for individuals in the program. That's to make sure that they're around like-minded individuals ready to engage in treatment. Use a standardized risk and needs assessment tool to make sure that we're targeting those individuals that are most likely to recommit crimes and try to impact that recidivism rate as much as possible. Develop individualized treatment programs, and that's going to include holistic approaches to behavioral health, as well as social economic issues, unemployment, and those types of things. And to provide MOUD, medicated assisted treatment, of which we have a program already in place that this program will supplement. This part of the slide always throws me off because the per US. So the services are going to be a coordination between us and, like I said, the community program provider, which would be Believe in Recovery, including job education or job training and education, recovery-based housing, self-help and recovery programs, and behavioral health treatment, as well as continuing any medications that were initiated while they're in custody. This program fits into the model that Lori's been talking about and impacts primarily in the Intercept 4 area for reentry and Intercept 3.
Great. Does anybody have any questions about either of those two things? I'm sorry, I didn't ask right after 4 Jim's. Okay, I'll launch into recovery. So these are the strategic plan actions that were come up with before we went after the grant. And then these are the items that are required from the grant. And over here, you see action notes around what we're doing that's recovery focused. And with recovery, is Brian Richardson here?
I am here, yes.
Oh, great, great. Go ahead.
Great. Yeah, thanks, Lori. Yeah, so I think if we're looking at this model on where Recovery Cafe sits, I might say that there's an argument to be made that because of the low barriers of entry to accessing the program, meaning that the only requirements to join are that you want to join, to participate actively, to like participate in your recovery circle, we ask for being sober during that circle. So I guess I would say it's most heavily on the very tail end, the recovery end, long-term recovery. But because you can enter at any stage of your recovery, you could access it on any point of this Intercept model. So I know I jumped the gun on your slides here, Lori. So we can go back and I'll just share a little bit about kind of what we've done amidst the pandemic and where we're hoping to go in the short term and this 3-year term for this grant. So since 2020, we've had 26 active members, and how we define that is someone who is enrolled in a recovery circle and attends that every week. A recovery circle is a 1 hour long support group led by a trained facilitator, either myself or another staff. You see a picture of Annie Lovato, one of our staff members here on the right-hand side. And it's a very open-ended processing group. There's no topic or reading necessarily, but folks are invited to share on how are you feeling right now, what's going on in your life, what support might you need right now, what successes and challenges are you having, and if you'd like any feedback, ask the group for feedback. So the idea with this is that we will train up peer leaders to facilitate recovery circles in the future. So you see another picture there of Kat Zecca, who is co-facilitating our newest recovery circle, which is a women's recovery circle. And the idea being that she'll become more comfortable. She's gone through training herself. We did a 30-hour Recovery Coach Academy training in January, all pre-pandemic. And so the two of them are facilitating together with the idea that Kat will become trained to facilitate her own recovery circle in the future. And we want to repeat this process to kind of create this peer support network. And these are folks who would do outreach in the community, facilitate more recovery circles, and be a support in the cafe space itself. So to that end, we've had 34 people, volunteers who have been contributing a ton of time to the cafe. A lot of the volunteer hours that you see there since January are like physically working on the building. But a lot of those hours too are volunteers making phone calls and contacting people and staying in touch while everyone has had to quarantine or at least drastically change their routines lately. And then what staff has done is we've been keeping track of, how many touches have we had with people, meaning either members who are enrolled in recovery circles or other people who are volunteering or other members of the community who have somehow expressed interest in Recovery Cafe. And so we do phone calls, emails, texts to make sure we're staying in touch with folks. And it's just a check-in, like, how are you doing right now? But we also get to know them better, learn what resources might they need and that we can refer them to. And for some, it's ongoing case management and enrolling into, say, Dove House services or other services. So there were 462 contacts that we made with 56 people since January. In addition to that, you guys probably know our AmeriCorps volunteer, Ben, who he completed his term of service, 1,700 hours worth. So I guess we can go to the next slide then, Lori. Yeah, these are just some of the other things that, like, none of us, of course, anticipated having to provide our services virtually or, in a really different way. So we try to make the most of it. We, in developing this peer network, had provided monthly volunteer trainings with the idea that people would learn things like motivational interviewing skills, healthy boundaries, communication skills, assertive, like listening, things like that. And so we moved those virtual, and anyone can go watch those on our website. Another offering that we're hoping to ramp up is classes in what we would call the School for Recovery. Those are on any topics that might be useful, things like, coping with your emotions. The one that we did start off with was nature journaling and meditation. So that was kind of an experiment to do it all via Zoom, but for what it's worth, I think it went pretty well. And again, these last points are different ways that we're trying to empower peer leadership. So we have an advisory committee of folks who are probably, I'd say, the most engaged members of Recovery Cafe. They help give us guidance on, hey, here's what I'm hearing in the community right now. They helped us form our new Women's Recovery Circle because they were doing outreach and learning, hey, I talked with somebody who's interested in getting more involved with the cafe. And so that's a referral source for us. I think that's it for this then. Yeah, I don't know. I guess that's all I've got to share for now, unless you want anything else for me to share here, Lori.
I do want to point people there. You've seen some links here. It's very interesting to go check out some of the videos of what's been going on over there. You guys have done a good job of sort of leaving a place where the community could keep in touch with what you've got going on over there. So thank you for that.
I guess sorry, I will say, because you know, our building looks, it's nice. Like we can actually use it now. Staff are officed there. So we're taking it slow. It's this tension, I guess, that I feel that we have to balance between the urgency I'm feeling of providing services to people now and virtually, but access it. That's certainly, it might benefit from these services and who can't do it virtually for whatever reason. So there's that tension I'm feeling, the urgency, and the tension I'm feeling of needing to keep everybody safe from the pandemic. So starting this coming week and in the next several weeks, we're starting to practice having hybrid recovery circles, some people in the space, some people virtually. We are seeing clients like individually here at the cafe. We've all that. Thought I'd put, we've always been looking forward to having a big grand opening date, and it's gonna turn out to be like a, I don't know, a softer start opening, if you will. It's balance between those two things. So I know that's vague, but I hope that helps people.
Yes. Thank you, Brian.
Laura, can I ask a question?
Yes.
Hey, it's Apple. Hey, Brian, it looks great. I drive by it every day. I'm so excited. Thanks for explaining all that. I have a question about advocacy groups, and I'm less familiar to Recovery Cafe, except for what I've learned from you on these meetings. I'm getting a lot of questions about parenting support through COVID. Parenting support in general is our wheelhouse in public health, at least in my division where we do family and nursing services, clinical work and stuff like that. Is there any connection between advocacy for parenting stress and recovery and substance use? I just wondered if there's anything unique like that that has been thought of or is done, or any ideas about that connection?
Thanks, Apple. I think I caught most of that, but what I was hearing you say was like the connection between advocacy and parent support. So I guess how I see things kind of evolving at Recovery Cafe is the needs that arise from the members that we have. We're going to do our best to use the community resources that already exist and get them hooked up. Like I saw Denise in the chat had put in about guiding good choices. We have a lot of good programs in the community, so I hope that we can help people better connect to those. And if our members are saying, okay, you know, that's nice, like I've tried those programs or whatever, or it's not quite what I'm looking for, our hope would be that we can develop something that would meet that need. That said, we don't provide childcare at Recovery Cafe. If an adult wants to come with a minor, we expect that they are supervising that young person while they're there.
And Apple, I'd like to add that the Empowered Teens Coalitions are offering Guiding Good Choices right now every Thursday through October, and those classes are going and full right now. Excellent. But it's also offering it every Monday through November, and those classes are all open. People can sign up for those, and we've put out flyers and had advertising in the newspaper and shared this information with the front desk. And so, you know, people just have to call Lindsay Scalf or call the health department or send an email to Lindsay, and I can get everybody that information if it somehow didn't get out to people.
Thank you. Yes, I have utilized that resource over and over again, and I'm glad to hear your classes are full. And I have told people recently about it as well. I just was curious about substance use and parenthood and the connection there, and if that is if there's advocacy around that in particular for adults. But this conversation is fruitful. There's always more to learn and more advocacy to do, and there's a lot of us doing really good things as it is on this topic. Thank you.
Thank you, Apple. That is a good thing to think about, and we can sort of weave that in as we go forward. as we look at October and what we'll be focused on there's the realm of what you see over here that we'll be working on. I think the big things that I wanted to take away, have you folks take away, because we'll be reaching back to you to talk about them. One is to get with each one of the members, look at what data is going to be needed on a regular basis and figure out how we can set it up so that we're getting it from you and it's not a pain for you. It's just a smooth process. And then we recognize that we really want to clarify the priorities for the members during this time of COVID. And John's going to talk a little bit later about the potential of streamlining some things and how we might go about doing that. So those are the two big things that I hope to really get better arms around by our next meeting in November. I'm going to skip these two slides because Jolene was called out last minute to a state level meeting. On the RCORP grant, the RCORP planning grant, I just wanted you folks to know that we have submitted the final closeout report. It was accepted. The very last thing that's really not due until next April, but I would imagine you get it in before the end of the year, is this final financial report, which has to be generated by Jefferson County Public Health's Veronica Shaw, who has handled the administration of the grant. And once that report is done, then we can check all of the boxes and close it out and hold on to the files for 6 years. And with that, I'm going to turn it over to John.
Hi, everyone. Hope you're all doing well in our interesting COVID world we're living with now. This slide is just a little reminder to you of kind of where we are. I want to talk a little bit broader about what's going on with CHIP in kind of the broader world. So I think most of you remember that we did a community health assessment last year, and part of that work, it's fine to go to the next slide, Lori. Part of that work was that we determined that we had a group that looked at that and tried to reevaluate the priorities, and they decided to shift the priorities from things like mental health and chemical dependency and immunizations and access to healthcare to health bans. And these health bans are youth, working age, and seniors. And for each of those age bands, they came up with some suggested priorities, but the idea was that eventually there would be a group for each of those 3 age bands. And those eventual age band groups would start to develop strategies, priorities, goals, and activities around those strategies. And so Lori and I were pretty much right in the middle of setting up those groups, and COVID hit, which was a real challenge. And so we've been kind of evaluating what to do about that. So what are kind of the next steps that we want to do? We've been talking with some community resources about next steps. I think there's a lot of concern about duplication of efforts in the community. A lot of groups are doing kind of similar work, and then there's been these new ICC teams that have been formed to also do some similar work. So there's a lot of concern about duplication, and one of the strategies that Lori and I have always employed is we want to try to help groups that are working on similar activities to integrate as much as possible. The second bullet is really around, we just want to make sure that as we move forward that we're putting our CHIP resources towards the most good. So basically, you know, the long and short of it is that we have decided to kind of put a pause on redrafting the CHIP plan, and we want to put our energy into supporting some of the activities that are going on in our community right now in terms of COVID, like the work with the BHC that you guys are doing, and try to kind of reset and then think about putting these age band groups back together as we start to tail out of the COVID crisis that we're in right now. Lori, can you go back one slide for just a second? Yeah, so in terms of streamlining efforts, this is an example that I think should appeal to most of the people in this room, because here are, 5 groups that'll, probably several of you are in at least 2 and maybe more than that. And then at the bottom is a quote that Lori pulled out when she did interviews with some members of the BHC about, duplication of efforts. So what we would like to do is, maybe not so much eliminate groups, but at least establish boundaries around those, and then look for opportunities to combine the work of some of these groups if it's possible. So we're working with some community leaders to figure out how to do that. We hope that if we, if we can't consolidate or combine groups, that we can at least more clearly define the roles of those groups so that they're not duplicating efforts and it's really clear about what they're doing. And Lori and I participated in pretty much all of those groups, one or the other of us or both of us. So that's kind of our goal. We are going to look at things like, there's already a Children and Families ICC team. Could that group morph into the age band group after it's done doing that work? And we really want to support the other activities that are going on in the community. And I think that is the last slide for me, Lori. Yep. So,
thank you, John.
Yeah, thanks.
Any questions on that part from any folks?
Yeah, I have a question. It's Denise, and I'm wondering what the youth age band thing, what is that?
Well, it's just the idea that instead of grouping things around things like mental health, like behavioral health and access to care, immunizations, chronic disease prevention, the group that looked at the community health assessment thought it might be more helpful to look at issues in terms of different age bands. So one of those age bands is a youth age band, and it's looking specifically at the kind of issues that youth and teens have, and how can we help them to address those issues. And then there's a working age band and then an elderly band. And the idea would be that they're...
I get you, John, now.
Okay.
Go ahead. The idea would be to...
Yeah,
what?
the idea is that we would form groups around those 3 age bands and that they would establish priorities, and that would help us to draft a new CHIP plan that's based on age bands rather than on the 4 priorities that we had used previously.
Okay, and so you're saying these will be formed, meaning they're not formed yet.
They're not formed yet. We actually started that work. We sent out some emails to folks and said, we think you might be interested in this, but that's where we've put things on pause at this point.
Okay, so I think that I have responded to that youth age band email.
You probably did, yeah.
Okay, all right, great. Thanks for clarifying for me. I appreciate that.
It was a good question. I'm sure it was on other people's minds as well. Any other questions for John? Okay, we'll go into Lisa Grundl's presentation. Lisa, you just tell me when to move a slide forward.
Okay, I will. So hi, everybody. Thank you so much for everyone that got us our data that we requested. We know we've been asking you and bothering you a lot for data, so we really appreciate the time that you took. You'll see, we'll go through these slides, and we're going to go pretty quickly, one, because we're going to be out of time, but also because you'll see as you look at your own data that maybe we took some liberties with your data. We rolled things into categories. We tried to annualize some data just to get a picture of things. And I talked to John and Lori about loving to connect with each of you individually between now and the next time we do a data release. So what we've tried to do is develop some Excel spreadsheets for each of you where you can just update that data. But it was a little bit more challenging than I had remembered because there's some definitions that have changed along the way, and sometimes there's more detail and less. And so we've kind of tried to create these files for each of you where we could just make it much easier to update. And I think along what Lori was saying, we know everyone's so busy trying to make it as streamlined as possible. Of course, the goal of this data is to just really keep better understanding what's going on in the community as far as how many people need these services that we've talked about providing, both in terms of inpatient or crisis stabilization and other services in the community, and understanding what that looks like. So I'll try to go fast here. So here's the first slide is East Jefferson Fire Rescue. And so they've experienced on average about 160, although 2020 seems to be driving some of that data. They were closer to 150 before. It looks like they've increased in their behavioral health responses. Again, we took some leadway in this by annualizing some data. And so, it'll be interesting to see as we get the next months if that turned out to be true or if they just had some spikes that impacted that. And so, again, behavioral health, mental health is the biggest set of types of responses they receive. You can see in the pie chart to the right there. And still, Lori's at the next slide. I think it's the next slide. Oh yeah, and in the next slide, it talks about just their opioid overdose incidents, and those also have been going up since 2017. They're still smallish numbers, but continuing to go up, and 76% of those are transferred to Jefferson. And I actually just got new data that's not included in this today that shows that it seems like an even higher percentage are going to Jefferson in this next round of data than were in the previous rounds. So Jefferson Healthcare had a total of 732 behavioral health ER visits in the most recent 12-month period through August. Again, they are majority mental health. 82% of their behavioral health ER visits are mental health. And you can see how that kind of has tracked over the years from September of 19 through August. And May and June did seem to have a spike. We were kind of looking at some of this monthly data to see is there something related to COVID. I would say if I had to pick a month that maybe is COVID related in a lot of these data slides, it would be June. And you see that in Jefferson. I don't know if that was just too many months of stay at home, and then once people kind of got out to get out a little bit more, but it seemed to have a little bit of a spike for Jefferson. We'll go to the next slide. And again, I think we've said this before, it continues to be true. Their mental health patients are largely Medicare and Medicaid, and SUD patients have a higher reliance on Medicaid. And this is important as you look forward to any service you want to create to understand that public payers are going to be a large chunk of that, and understanding what that does to your financial viability, and understanding what rules we'd need to be having with the healthcare authority and Medicare and setting up those systems. We have tried to get some discharge data from Jefferson, and I know that Jefferson is doing a lot of work currently, I think, on trying to refine their data. They do show that a majority of them are going home, but we know that we looked at that home, there were some other elements in there, and so we do think there are a percentage of those are going elsewhere. And that currently, and I don't know if anyone from Jefferson Healthcare is on the line that can answer this, but it looks like about 60 patients per year are going to inpatient psych. And I didn't know if that was just inpatient psych at Jefferson or if that was anywhere outside the community too. So I'd love to drill down on that. If anyone can speak to that now, or as we do these follow-up calls, we can get some more information on that. And again, it's just showing the age groups clearly. It's not surprising, it's 25 to 64, very few children in the SUD, and very few 65 plus. So the focus definitely is on that mid-range. Discover Behavioral Health, ITA, they have, let's see, I don't have the number on here, but of their ITA investigations, only 20% result in involuntary detention, and then the 80% are referred to different levels of mental health or SUD into the community. I think on the next page, it shows more detail, Lori, I think. Yeah, so this is just give some numbers. Between May of 19 and April 2020, it was the solid year that we had of what are the numbers of people being referred to other services, and clearly outpatient mental health and voluntary inpatient mental health are the two big buckets. And you see that there's only 2 that referred to crisis triage. And I, again, in drilling down on some of this data, would love to know if some of the people that really could have fit into that crisis mode were referred to either inpatient or outpatient services, and what that could look like, but it'd be interesting to get more data on that as well. I'm trying to watch time, see if I'm taking too much time. And this is just another interesting thing. Again, I keep talking about what happened in June. It seemed like, as I looked at a lot of the data, May, June, and particularly June was a big month. And in ITA investigations, certainly DBH had their biggest number of investigations in June. And the biggest increase in referrals during that month was to outpatient behavioral health services. So that was interesting to point out. Jefferson County's jail related bookings, almost 75% are SUD related, which is different than some of the other categories we looked at that were mostly mental health. They gave us some really good drill down this time on different reasons that they were booked, or not just reasons where they're booked, but assessments that were done as far as if they had reported an alcohol problem or reported prior suicide attempts. So it was really great data to look at as far as being able to parse out what are the issues that are being faced in the jail. And still 75% are definitely related to SUD. And this also, just as far as trying to look at this COVID impact, Jefferson County Jail's behavioral health related bookings saw a huge decrease in March, and they still remain below COVID levels. And I assume that was true across the jail, not just for behavioral health related bookings, but I know that's not surprising, but just thought it was interesting to see such a drop and then still not back up. The majority of Jefferson County Sheriff's behavioral health related incidents are mental health. So again, we see different depending on the entity. Some are more focused on SUD, and Jefferson County is definitely more focused on mental health. However, when you combine drugs and alcohol, it gets closer to about 50-50, but if you combine those together. Let's see. And this is just showing a year of data and showing how it kind of ebbs and flows. And again, in this data, it actually showed some spikes in April, March and April for SUD and then for mental health. But it looks like the data between May and August is stabilizing again. This data, again, some drill down we'd like to do is get those months separately between May and August and just kind of take a look and see what happened in May and June. Were they spiking still and now they've gone way down in July and August, or did it really stabilize right after April? I know I'm going fast, but I think I'm almost out of time. So the good news is we just wanted to really give a high level update on this, and then hopefully we'll be able to do some of these drill downs with people individually and get a good presentation again in the next couple months. So this is Port Townsend Police Department. Again, 86% of their incidents are mental health, and 27% include, boy, all of a sudden can't see my slide there. Make sure it's alcohol and drugs. See, that's what it is. And then, yeah, 27% include alcohol and 10% include drugs. And then they did a nice job too of giving us some more details on the ones that involved SUD. If you look, that they have some numbers in here of which instance involving SUD, what was the issue was. So some just were general involved alcohol, some involved illicit drugs, and then some involved both alcohol and illicit drugs. So it's just kind of nice to see that breakdown. Alcohol clearly was the predominant substance related to SUD incidents. And then with SUD and mental health, just another really nice breakdown of what were the issues there. It was interesting to kind of take a look at how those broke down. So appreciated that level of detail. And then this last slide is some work that's going on in the jail around inmate evaluation recommendations. And you can see kind of the percentage of evaluations being done on inmates where those are recommendations, referrals are going to. Largely, again, outpatient and inpatient and MAT. So MAT and inpatient are the two largest referrals that are coming out of the jail. And then the other thing that we have here is just a showing of their relapse prevention that they're doing in the jail. And it shows that, I can't see my slides on your thing or anywhere, I don't know what happened. They have about 13 participants per week on average. So it's they're doing some good work there in relapse prevention, and this is data we haven't shared before, and there's some more drill down we can do, and even more drill down they've already provided to us that we could do at the next go around. So that was a lot of information really quick. Did I make my time? Oh, we have 5 minutes left.
So question.
Any questions?
We will come back around and have a more airy schedule to look at this, but we wanted to at least take what you've given us and get it out there, and we can take some time with it at the next meeting.
And I'd love to hear back if you think I missed the boat on what was important in your data, or if I rolled things up in ways you're uncomfortable with, or any of that. We'd love to get this really refined before the next go around. So
this is Jim. I just got one quick question. When people are identified as being in the jail, especially in the police department and the sheriff, as a mental health, how are they determining it? It's a mental health issue? Is very interesting to me how they make that determination. And then second of all, how many of those individual, 438, the numbers, how many of those are repeat people, or is it a unique individual? I think those are numbers that we really got to look at, because it could be skewed. Sometimes one person could have 10 or 12, 15, 20 interactions with the police department. Is that included as separate, and I think those are the numbers we would maybe refine better, how many people are actually showing up with those kinds of issues. The same with SUD, probably, I would think the same thing.
Yeah. And I know we discussed before some of the challenges with how people are determining whether it's a mental health or SUD patient interaction. And that's a good question. I think maybe we can even have some people already talk about that a little bit more, as far as from Port Townsend Police Department or Jefferson Sheriff's Office, how they make those determinations. I think that'd be interesting, but I know that they've really tried to drill down on that and be more clear. And you can see in some of the breakouts that they're really identifying what those criteria are that put them into each of those categories. And that's one of the questions I had for them when we meet on this data, is understanding better where they fall into each of those categories, and is there overlap we're missing. Repeat, that's a challenging one, I think. That was a challenging one, and one of the things we've had, not just with repeats with the jail or the police departments, but also how do we know if the same people that are at Jefferson and at the jail and at the Port Townsend Police Department and at East Jefferson Fire Rescue, how many of those are unique individuals? And that is a struggle that we haven't come up with a specific way to really address that, but I think we need to keep talking about that too. I agree that that's one of the things we need to figure out, is what's duplication. And then the flip side of that is, who are we missing? Because I know we had this conversation before about we're probably only seeing the people that's at the tip of the iceberg. There's probably a lot of people that aren't encountering anyone potentially, and how do we count those too? So there's still some work to be done for sure.
Thank you.
I always feel like when we get this data, we introduce more questions than we actually answer. But we got a good, we've been doing this for, I don't know, more than a year now. And it feels good to at least have some kind of a baseline and know what the questions are that we should be asking each other, and what sorts of things need to be clarified. Yeah. So Lisa, thank you so much for doing all of that with the range of what we gave you. And we'll look forward to digging into it more at the next meeting.
Sounds great.
I'm going to skip quickly over Addictionary. We'll introduce that at the next one. I want to highlight the fact that, I really appreciate that everybody is still showing up, even though we're not coming to a room and actually meeting with each other, face to face. I appreciate your continued engagement. It really makes a difference, I think, as to how we are going to weather through what a lot of people are saying, might be a really challenging next 6 months. And the fact that we're at this table and I can count on you guys being here, and that you'll pick up the phone in between the meetings when I call. I think that we are as well prepared as I might have dreamed we could be for what we had to deal with going forward here in this next 6 months. I wanted to highlight that our next meeting will be on November 12th at 3 p.m. and also that there is a special Behavioral Health Advisory Committee meeting on Friday, October 16th at 3 p.m. where they'll be talking about the next RFP cycle. Are there any questions? Now, I know we're at 3:59. You're welcome to stay as long as you want, but I wanted to give people a chance to get off if they needed to go elsewhere for their next meeting. Okay, don't everybody talk at once.
Definitely.
All right, well, I'll just assume that you guys, this is like being after Thanksgiving dinner, except it's information and not turkey that you just ingested. I'll look forward to reaching out to pretty much all of you in between now and the next meeting to go through the information that we're going to be gathering for HRSA so that we can understand how we can do that most efficiently. And then also to talk a bit about what of the strategic plan items should we raise to a priority level and what might we drop back until maybe next spring or summer. Any other questions? If not, you're all welcome to chat or go on to your next thing.
I was just going to say I really appreciated that data. And I do wonder, do you know when the next CHIP oversight meeting would be with the and are they going to get at that level? Are we going to get to see the similar data, especially the jail data? It's just like so interesting seeing those trends.
Go ahead, John.
Yeah, Matt, I emailed Mike Glenn about that. We, obviously with all the COVID stuff, we've kind of been putting off the joint boards meetings, and Mike would like to wait till after the first of the year to reconvene the joint board. So I think that's the next time we'll all be getting together. But I think we're more than, we post all this data on our Be Healthy Jefferson website, and we're more than happy to share it with any group that has an interest.
Yeah, that was one of the things I was going to say. We're happy to, we have tons of presentations we can take on the road. So if there's any particular aspect of anything that you'd like to hear with a small group, we're happy to do that with you. And
now we don't even have to get in our cars to go on the road. We can just stay at our desk.
Okay, I'm just looking to see if anybody else has hands raised or anything. Thank you so much for coming today. I hope you have a wonderful rest of the week and weekend, and we'll see you next time.
Thanks so much.
Bye-bye.
Bye-bye.
Have a good one.